Yes. Good afternoon to all of you. So for the next half an hour, you will be listening to the topic respiratory distress in the newborn. So I will tell you the basic things that you need to know about respiratory distress in a newborn baby. As all of you know, a newborn baby is a baby who is less than 1 month old. And just to introduce myself, I am a consultant neonatologist working at Sri Jayawardenepura Hospital. Yes, so at the end of this lecture, you will get some idea as to what is respiratory distress in a newborn baby, then how to detect respiratory distress, that is how you would identify a baby as having respiratory distress, and what are the causes that can cause respiratory distress in a newborn baby. You will also learn how you would manage respiratory distress as a doctor just beginning your career. Right? Even you are just starting, you should know how to manage the basic things until help comes, until a senior doctor will come and assist you. And then I will tell you what are the consequences of neglecting respiratory distress. You won't neglect respiratory distress if you know it, if you know to identify it. But if you do not know how to identify it, or if you identify but if you don't take a step to manage it, that will cause what will happen. Okay, so what is respiratory distress in a newborn? In very simple terms, respiratory distress in a newborn is some form of difficulty in the of breathing in a baby. Okay, it is some form of difficulty. It doesn't have to be a high respiratory rate all the time. Yes, and where will you see these babies with respiratory distress? You might see them in the labor room. You might identify a baby having breathing difficulty in the labor room. That is the most common place that you might find a baby with a respiratory problem. Then you may see a little baby with the mother in the postnatal ward having some kind of breathing difficulty. You may also see a baby in the pediatric ward having a respiratory difficulty. Maybe the baby has come for something else. Maybe the baby has come for poor feeding, or the baby has been admitted for jaundice. But when you go to the baby, you notice that there is a respiratory distress. So you have to take action. And you might also see a baby with breathing difficulty in the well baby clinic. All of you know that there are well baby clinics run in hospitals where we see the sort of normal babies at 1 month or 6 weeks. So the baby will come for a normal checkup, but as the doctor attending to the baby, you will feel that this baby is having some kind of respiratory problem. So you will know now you should not just let that baby go home, but you have to alert a senior doctor. And you might see these babies in the pediatric or the neonatal clinic. Maybe the baby will come because of jaundice, or the baby will come with a fever. But when you look at the baby, you know that the baby has a breathing difficulty. And again, if you are working in a what you call PBU, special care baby units, the baby is there for something else. Baby will be there admitted because of jaundice, or because the mother is in the ICU, or because the baby has a fever. But when you look at the baby, you identify that the baby has a breathing difficulty. So in all these places, you may identify babies with breathing problems. So now we will see how you would diagnose that a baby has a respiratory distress. That means, in other words, what are the symptoms and signs of respiratory distress in a newborn baby? The commonest respiratory distress that we see in newborn babies is tachypnea. As you know, newborn babies, the respiratory rate is anyway a little high. And sometimes they have something called periodic breathing, where they will breathe a little rapidly, but then they will settle to normal breathing. So in a big person, in an adult, the respiratory rate is around 20, the maximum. Then in a child, it will be about 30. In an infant who is less than 1 year, it will be about 40, the upper range, upper limit. But in a little baby, a newborn, we call them to be having tachypnea if the baby's respiratory rate is more than 60. So one common feature that you see in babies with breathing difficulty or in respiratory distress is the baby having a high respiratory rate. And grunting. Another very important feature in a baby with breathing difficulty is grunting. I hope all of you know what grunting is. Grunting is a kind of a labored noise that comes out of your throat when you breathe. We commonly see it in very elderly people when they are sick, they grunt, like that kind of sound, right? So in babies also, sometimes the baby may not be having a high respiratory rate, but the baby shows a grunt. That is a very important sign to indicate that the baby has a breathing problem. Another sign that you will see, another clinical feature that you see in these babies are recessions. The recessions can be intercostal recessions, then they can be suprasternal recessions, and they can be subcostal recessions. Those recessions can be in 3 places. I'm sure all of you know what recessions are. You would have seen in small babies, right? Then another very important sign in respiratory distress is gasping type of respiration. All of you know gasping comes towards very last stages of respiratory distress. Gasping is what we mean by gasping is a very labored, really difficult breathing. If you just allow gasping to go on and on, they will stop breathing. So gasping respirations are very difficult breathing attempts, which you all of you would have seen in adult wards. Then the patients are, near death, they gasp, like they breathe with so much of difficulty. So something like that you can also see in babies, which is generally quite a late sign. Then you can see apnea, right? Apnea, that is complete cessation of breathing, is also a sign of respiratory difficulty. So initially what will happen is the baby will be apneic. Then after about a few seconds, maybe half a minute, he will start breathing again. Then again he will become apneic. So if you allow it to go on and on, they will stop breathing forever. Apneic attacks will build up for a total apnea if you just neglect. And another common thing which is associated with breathing difficulties is cyanosis. As you know, cyanosis can be there in heart disease. Likewise, it can also appear in respiratory difficulties, right? All of you know why cyanosis comes up. When the cyanosis manifest when the deoxygenated hemoglobin in the circulation exceeds a certain level. Yes, this is just a picture to just recap what I have told. It can be tachypnea, it can be cyanosis, it can be nasal flaring, it can be grunting, it can be apnea, it can be recessions. So all these signs are signs of breathing difficulty, respiratory distress in a baby. Yeah, this is just for you to see some pictures of cyanosis. The first picture shows because in dark skinned babies, usually we are dark skinned people, so in the dark skinned ethnic groups, cyanosis is not that prominent like in the fairer group of children, because babies are also slightly on the dark side and their lips are also not bright pink. So a nice area to pick cyanosis is most of the time we see cyanosis around the lips. In this first picture, you see this slightly gray ash color around the lips. That is a telltale sign of cyanosis. Now, if you really look at the lips per se, they don't appear dark, right? But around the mouth, you can see a very ash-like tinge, which is indicative of cyanosis. Second picture, you can see that baby, of course, the lips are a little cyanosed. It's not pink or red. It's like slightly purplish. Again, the third picture also you can see this is how sometimes in babies cyanosis looks in the tongue and the lips. Rather than blue, it looks quite purplish. And even in this baby, you will see the slight perioral cyanosis. And the fourth picture shows you cyanosis in the hand. Now, usually central cyanosis is very, very significant. Now, what we call central cyanosis is cyanosis which we see around the mouth, in the lips, etc. Now, in the hands, sometimes when the babies are cold, when the weather is cold, you see a tinge of bluish discoloration in the hands and feet of babies. If you when you give them a bath, or during early morning or late night when the atmosphere is cool, you might see this slight tinge of blue. But if you warm the baby, for example, if you put mittens or socks, or if you keep the surroundings dry, that will resolve. But if it is due to a respiratory problem or a cardiac problem, it will not resolve. So sometimes hypothermia causes a little bluish color which might get mixed up with cyanosis. So if you are confused, what you can do is you can just warm that area and see, or you can additionally, it will prompt you to look at the mouth and the perioral area. Then you can confirm the cyanosis. Again, this picture I am showing you to show mainly the subcostal recessions. It's not a mobile, it's a still picture, but you can very clearly see in the baby just above the umbilicus the V-shaped area which is due to subcostal recession. And the same baby you can see towards the right arm, near the right arm, the intercostal recessions. They have taken the picture at that moment. And again in this baby you can see, look at the perioral area, it's bluish, and here even the lips are kind of purplish or bluish. So that is cyanosis. Yes, now I have told you the features of signs and symptoms of respiratory distress. Now we will see what are the causes of respiratory distress in newborns. The commonest reason for respiratory distress in newborn babies is prematurity, where they have surfactant deficiency lung disease. All of you know what surfactant is, and in preterm babies they are lacking in surfactant, so they get surfactant deficiency lung disease. You can also call it neonatal respiratory distress syndrome. Then some people call it, those days we used to call it hyaline membrane disease, and some people call it idiopathic respiratory distress syndrome. All are the same. So it is one of the commonest causes of respiratory distress in the newborn. They will be tachypneic, there will be subcostal, intercostal, and sometimes suprasternal recessions. There will be cyanosis, there will be grunting. So all those features will be there. Then another group of babies who has respiratory distress are babies with Meconium aspiration syndrome. All of you know what happens in Meconium aspiration syndrome. The baby is surrounded by meconium, and the baby is hypoxic as well most of the time, and the baby takes deep breaths and draws meconium into the lungs, which causes severe respiratory distress in the baby. Then the other group is congenital pneumonias. Some babies during delivery, around the time of the delivery, contract a bacterial pneumonia from the mother, because the mother's vaginal tract has bacteria. They are commensals for the mother, but they are dangerous for the baby. Mostly it is streptococcus, and this streptococcus bacteria can enter into the baby's respiratory tract and cause a congenital pneumonia. So these babies will also have increased respiratory rate, tachypnea, cyanosis, all the things that all the features of respiratory distress. Then another group of babies who will show respiratory distress is congenital babies with congenital heart defects. Right? So because they have congenital heart defects, they find it difficult to there is either mixing of blood or their cardiac output is not good. So as a result, they will need to breathe faster to deliver the amount of oxygen needed for the tissue. So they will also present with respiratory distress. Then septicemia. In septicemia, why do they get respiratory distress? What happens in septicemia is when there's septicemia affecting the organs of the baby, it will lead to a metabolic acidosis. So when there is a metabolic acidosis, the blood pH drops. And to correct this, the baby has to breathe faster and faster to get the pH back to normal. That is, he has to wash out carbon dioxide and try to cause an alkalosis, which will balance that pH. So in septicemia, the babies get metabolic acidosis. To overcome that metabolic acidosis, the baby breathes, and then what we see is maybe a sick baby, but the baby has respiratory distress and baby is tachypnea. There are some other causes of respiratory distress. They are birth asphyxia, or what we call perinatal asphyxia. A baby can be hypoxic due to various reasons inside the uterus or at the time of delivery. So when these babies are hypoxic, again they become acidotic, and the perfusion to the lungs and the perfusion to the heart is also compromised. So they can present with the respiratory distress. Then certain babies with inborn errors of metabolism. When there is inborn errors of metabolism, again they are very acidotic. They go into a metabolic acidosis due to accumulation of the byproducts. They go into a metabolic acidosis, and to compensate, the baby starts breathing rapidly to wash out carbon dioxide and to correct that pH. Then congenital myopathies. When there is a congenital myopathy, what happens is baby is fine, the lungs are fine, but the respiratory muscles are not working properly because the muscles are diseased. And when the respiratory muscles are not working properly, what happens? Their respirations become shallow. I mean, they can't use their muscles. Their muscles can't support well for the lungs to get inflated. So they get shallow breathing, and when the breathing is shallow, to compensate for that, the rate has to obviously go up. If the breathing is shallow, you have to breathe at a more rapid rate to get the same work done. And the other group is congenital neuropathies. Here the lungs are normal, the muscles are normal, but the muscles will not work because the nerve supply is not quite good. Therefore, again, the same problem as in myopathies, their breathing is not that, the intercostal muscles are not working properly. So they will use their diaphragm and the abdominal muscles more and more, and they will have difficulty in breathing, because then you will see a lot of abdominal breathing, lot of subcostal recessions, right? When the baby tries to breathe, the chest won't expand, but the diaphragm will push down and the tummy will blow up. So you will see what is called seesaw kind of breathing, and that also indicates respiratory difficulty. Yes, if you go to less rare causes, but which are very, very important, there are certain surgical conditions which can cause respiratory distress in the baby. One common thing is tracheoesophageal fistula. One common thing is, the commonest of the surgical conditions is congenital diaphragmatic hernia, which is a congenital condition where the diaphragm, there is a orifice in the diaphragm which is supposed to close towards time of delivery, but it does not close. So through that orifice, the abdominal viscera get into the lungs, and the lung can't grow on that side, and there is no space for the lung to breathe. So the baby is in severe distress. Like that, in choanal atresia, where with the choanal atresia, the baby will find it difficult to breathe from the nose. So the baby will have to open the mouth and breathe through the mouth. And whenever the baby cries, baby is pink because he opens the mouth. But when the baby is not crying, he is cyanosed. The tracheoesophageal fistula is also something similar, where there is a fistula between the trachea and the esophagus, and the food and everything can spill into the trachea, causing pneumonia and respiratory distress. Then there are certain congenital lung conditions like pneumothorax. Pneumothorax can happen at delivery. Sometimes it can happen after delivery. During resuscitation, it can happen where the pleural cavity on one side blows up with air and it will collapse the lungs. Then there's another congenital condition called cystic malformations of the lung, where the lung has not alveoli, partly or in multiple areas, large cysts, which does not work properly as alveolus. They are like balloons, with just balloons, and sometimes they rupture and they do not do the work of the lung. Therefore, the functional lung tissue is reduced, and that little amount of lung tissue which is working normally has to work more. Obviously, then you will see a respiratory distress. Yes, these are some x-rays which just to show you how this is an x-ray of a baby with surfactant deficiency lung disease. If you can appreciate it, you will see like we call this ground glass appearance. You see very spotty, tiny, like, you know, it's like sand. Ground glass appearance of the x-ray. This is classical of surfactant deficiency lung disease. So this is surfactant deficiency lung disease. Then you get, surfactant deficiency lung disease. A few things about surfactant deficiency lung disease. It happens in preterm babies who are less than 36 weeks. It starts usually, surfactant lung disease, the symptoms start very early, within 4 hours. They need admission, they definitely need admission to the special care baby care unit or NICU, and they need respiratory support. So it's these are the basic things about surfactant deficiency lung disease. And they can be treated with surfactant. You know, surfactant can be given through a ET tube into the lungs, and then generally with other support the baby will improve. Now again, this is a baby. This is the X-ray of a baby with meconium aspiration syndrome. It is different to NRDS X-ray. You can see, you can appreciate this honeycomb appearance. It is small areas, multiple areas of air trapped inside the lungs, because meconium acts as plugs, and it gives this ball valve effect where you can inhale, you can inspiration happens, but you can't expirate the air, and it gets blocked inside the lungs because the meconium plugs are blocking the small bronchioles. So you get this soapy appearance, or like you get this honeycomb appearance. We call it honeycomb appearance, where there is trapped gas inside the alveoli. So meconium aspiration syndrome usually occurs in term and post-term babies, because very preterm babies do not produce meconium. So the baby is usually more than 35-36 weeks of a POA. And it is very, very commonly associated with birth asphyxia. So much so that they say if there is meconium aspiration, that baby at some stage has had some degree of intrauterine or perinatal asphyxia. That also occurs within 4 hours of birth. That also occurs just like hyaline membrane disease, because it happens already by the baby. By the time the baby is born, meconium aspiration has occurred. So symptoms start quite early. And definitely this baby needs admission to the special care baby unit, and that baby also needs. And this is X-ray for you to see what? Congenital diaphragmatic hernia. Here you see on your left hand side, the whole of the small intestine has seeped into the lungs, and it's occupying the whole of the left side of the lung. So there is hardly any lung in the left. The heart has been pushed towards the right, So the right lung also can't work because there's a heart block in that side, and the baby is in severe respiratory distress. An interesting thing is these babies with congenital diaphragmatic hernia, they are very, very severely distressed. They are having severe respiratory difficulty at the time of birth, and you will get the feeling the stomach is quite scaphoid. The stomach is very empty looking. The stomach, in the sense, the abdomen is very empty. That is because there is hardly any abdominal viscera in the abdomen. Now, actually, in this baby, the stomach is still inside the abdomen, but most of the time, the stomach also goes up, and the abdomen is very, very scaphoid. So this is a medical emergency. If you do not diagnose, invariably the baby is going to die. So usually we suspect with this in a baby who is not having meconium, who is not preterm, but the baby becomes very dyspneic soon after birth, and we see the abdomen is very, very flat. Small babies, the abdomen is generally a little full. So this baby abdomen is scaphoid, and you have to quickly think of diaphragmatic hernia. Sometimes it's antenatal diagnosis. In antenatal scan, they diagnose diaphragmatic hernia. And a very important thing that you should keep in mind is if you know it is congenital diaphragmatic hernia, or if you suspect congenital diaphragmatic hernia, we should not give bag and mask ventilation to the baby. You have to put a ET tube directly into the baby. You can see in this picture, you can see the ET tube, endotracheal tube, through the trachea. You can see the tube just extending just below the sternal angle. And why we should not give bag and mask ventilation with the face mask is the more ventilation that more puffs we give, more we will dilate the stomach and the intestines with air, and it will block the expansion of the lungs further and further. It will increase the pressure in the lungs more and more because the viscera is in the thoracic cavity, and on top of that, we are inflating the viscera with gas we are giving by the face mask. So if you know, if it is antenatal diagnosis, or if you think that the baby is having diaphragmatic hernia, you intubate stat without giving mask ventilation. Yeah, this is an X-ray to show you a pneumothorax. This is a baby with a kind of a tension pneumothorax, and you can see to drain the pneumothorax, somebody has put a tube, and you see the lung collapse. So the pneumothorax is on the right side, the right lung is collapsed, and you can see this dark area where there is air. So when there is air, the X-ray will show it as very black area. So you see the collapsed right lung, air in the pleural cavity, heart being pushed to the left side, and again the baby will be in severe distress. So as a young house officer, as you are just starting work, how would you manage the baby with respiratory distress, which is very important because you may not know a lot, but you should know the basic things that you can do to save this child until help arrives. So how would you manage? If you see a baby has respiratory distress, whatever the cause, invariably that baby has to be admitted to the special care baby unit. And another thing that you can do is, if the baby is in respiratory distress and if you see cyanosis, that means the baby obviously needs oxygen. These are things as a young medical officer, as a person, as a doctor who is just starting work, you can do these things. These are not difficult things. So you can give oxygen, or you can tell a nurse that the baby needs oxygen, or you can tell a colleague. Right? You can write in the note, immediately admit this baby to baby unit. Then arrange respiratory support. A baby having respiratory distress will need respiratory support. It can be a CPAP, it can be ventilator. So you do not, as you begin your work, you do not know how to operate a CPAP, you do not know how to operate a ventilator, but you can say this baby might need ventilator, CPAP support. The other people will get it relieved because all the nurses in special care baby units and ICUs, they know to set up a ventilator, they know to connect a CPAP to the baby. All you have to do is to tell. And always inform a senior colleague. Don't try to handle things on your own beyond a certain amount. You do the little things you do, and that you have to realize that will not settle the baby. You do that, but inform about the problem to a senior colleague. And it is very important, what is called holistic management. So all these babies, if you see the babies in distress, you don't attend to the distress itself. You have to give the general care to the baby. You have to maintain the baby's temperature. If the baby is cold, you have to put into the incubator. You have to maintain his hydration. You have to maintain his sugar and electrolytes. So a baby in respiratory distress cannot be fed, right? Baby has difficulty in breathing, so he will not be able to suck from the mother. He might not be able to tolerate the feed. So you stop the feeds until the problem is resolved, and you can give IV fluids, you can order IV fluids, and you quickly arrange a chest X-ray to see what the problem is. Then always inform a senior colleague. I am telling you this, I am repeating because it's important. Then look out for cardiac murmurs. So it may be a cardiac congenital heart disease which is causing the respiratory distress. So listen to the baby, carefully do an examination. You know how to listen to murmurs. See whether there is a murmur. You don't have to diagnose whether it's a VSD or ASD, whatever. Just listen to a murmur. And there is a small machine called pulse oximetry. I'm sure you all know it. Connect the baby to a pulse oximetry and see the oxygen saturation, which should be above 92, right? And you have to keep in mind the babies can have congenital heart defects, which even very serious ones, without murmurs. So just because there is no murmur in a baby who is cyanosed, it doesn't exclude the cardiac problem. You know, like transposition of great vessels, hypoplastic left heart. You will not hear a murmur in these babies, but they have very serious heart disease. So just because there is no murmur, you can't exclude the heart disease. Arrange investigations quickly. So arrange a chest X-ray, which I told you before. Do a blood culture, send a CRP, send a full blood count. Do arterial blood gas if you know, or get help from somebody to do the arterial blood gas, which will give a lot of information, right? Then give antibiotic cover, which is very, very important. Whatever the respiratory distress, we can't at once say whether this is infection or not. So whenever there's a respiratory distress, we start antibiotics after sending cultures. So it may be a heart disease and the baby may not need antibiotics, but we don't know at the beginning. So you have to always start antibiotic cover. So yes, now we have come towards the end. Why is it important to detect and manage respiratory distress early? So the whole purpose of telling you this is how to detect, how to manage, and why you should take action, right? So most of the conditions because this is the reason, most of the conditions leading to respiratory distress are treatable. So if you detect it and if you do the initial steps or inform your colleagues, you can treat it. If you detect and take necessary action, you can save the baby, right? If you delay action, the baby will deteriorate further. For example, you see that the baby is having respiratory distress, you don't know what to do. You decide, I will just pretend I did not see it and just let the other person diagnose. So that's not the way. If you detect it, it's okay. You don't know what to do, but you have detected. So detecting is as important. Maybe it's at your level, it's more important than management. So you detect it and you tell it. You may not be able to do anything, you tell it. So you will avoid the baby getting deteriorated any further. And if you miss it or if you neglect it, the baby will die. So these are the reasons why you should take action and know about it. Okay, so thank you very much. So I think you got some idea of how to manage